And without further ado, I will hand over to Professor Clare Sharpe, consultant kidney doctor at King's and chair of the Kidney Network COVID-19 Clinical Advisory Group. Clare.
Thank you very much, Rob. And thank you everyone for joining this second session of the day. This really is a follow-on for those of you that remember this time last year when we had, I think it was on the 1st of July last year, a reflective meeting about the first wave of the COVID pandemic. At that time, we weren't necessarily anticipating a big second wave, but we did realise that we had to learn from what we had been through, and that the importance of collaboration and coming together and sharing our experiences. So today's session is another opportunity to do that. Hopefully it will be more enlightened. We now know that we're living with COVID-19 probably for a very long time to come, to reflect again on what we've learned, but also really to look forward in a much more coordinated and collaborative way. Next slide, please. So just a little bit of context about the COVID-19, what had become to known clinical advisory group. This was very much a clinical collaborative grouping of people that came together over the last year or so to talk about ways of clinically managing COVID. We were aware that there was a lot of operational activity going on around organising dialysis units and transport and all sorts of things, but we wanted to come together across London with representatives from the multidisciplinary team, doctors, nurses and patient representatives across London to talk about how we clinically manage with patients with COVID-19, not to have to think so much about the operational side of things, but how can we actually focus on how do we protect these patients, how do we treat these patients, and how can we use what we're learning in London and potentially try and share that information. I hesitate to say best practice because we didn't really know what best practice was, but how do we share that information with other groups? So we were quite a flexible group. It was an open invitation. People, all renal units in London had an open invitation, and some people joined some meetings and others. And we invited people when we knew we were going to be talking about something that was of particular interest to them. We were met mainly weekly, but in quieter times we went down to fortnightly. And we had a few outputs which we think were helpful to other people. So we initially wrote a guideline on managing transplant patients with COVID-19, and that was later adopted by NHSBT and BTS and taken forward by Gareth. But we also had some recommendations on the use of remdesivir and some information for staff on COVID-19 vaccinations. So we think many of these things were useful. One of the other things that came out of the COVID-19 collaboration, Pan-London collaboration, was a data group. We realised that how important it would be to be collecting our data as we went along and to look at it in an unbiased way, to try and look at how our practices were impacting on the pandemic. And some of the two main talks we have in the next session really come out of that collaborative data collection. So next slide, please. So it's my great pleasure to introduce the first speaker, who is Ben Caplin, is a nephrologist you all know at the Royal Free Hospital in London, and he was pivotal in the Pan-London data collection group, managed to cajole all of us to collect our data across London to look at transmission in dialysis units, which we realised very early on was a key aspect of the pandemic. So I'd like to now pass over to Ben, and he can share his data with us.
Thanks, Claire. I hope you've got my slides.
Yeah,
I hope someone's got my slides. Thank you. Thanks, Claire. As Claire pointed out, the data group kind of evolved from the Pan-London clinical group, which was set up by Claire and colleagues. And we realised that we were in a pretty unique position in the sense that we had 7 big units who'd all been badly affected by COVID during the first wave. In fact, we're slightly missold here because I'm going to talk about our experience in the first wave rather than the second wave. There were several areas we highlighted that we thought we could collect data on that would be useful. Dialysis units, which I'm going to talk about. I know Deb is going to talk about some of the inpatient data we collected, and we also collected some data on AKI. So I'm just going to focus on dialysis units. that are the map of London. That's all our satellite dialysis units, or most of them. I think a couple fall off the bottom and a couple are missing for other reasons, but that's all our satellite units are coloured by the main renal centre. And it occurred to us very early on that we were all trying to stop our dialysis patients getting infected by COVID, and we were all doing slightly different things. And we thought, given that we had over 7,000 patients on dialysis and on in-centre haemodialysis in London, that perhaps we could conduct some comparisons that might help us try and understand what things worked and what things didn't. Have my next slide, please. So, I mean, all of us were following at the beginning of the first wave of COVID, were following European guidelines, and I put them up here. They were published in NDT very early on. The recommendations for the healthcare team about using PPE in patients with suspected or confirmed infection, but not in those we didn't think have infection. And similarly, some recommendations about screening patients on arrival in dialysis units and those that we suspected to have disease, and how we would isolate those suspected to have disease. So I think we all tried to do that. I guess what varied was how we managed other things. So, for example, did we manage all the patients? And I put an infographic on the right-hand side of the slide, which describes some of the differences of different centres and even indeed different units within dialysis units within centres we're using to try and mitigate the impact of COVID amongst the dialysis population. And for some units, dialyzed patients who confirmed COVID positive on a different site, in an attempt not to affect other patients on the same site. Sometimes we use different shifts. Almost everyone tried to get everyone into side rooms, but some units ran out side rooms and had to use physical separation. Then we managed patients who arrived with suspected symptoms but without confirmed diagnoses differently, and again, similarly, either off site or in side rooms, or with people who had disease sometimes. And then there was people who had negative swabs, and there was some concern early on about whether negative swabs were always, whether they were true negatives or false negatives. And so there was some people who returned those patients immediately to the usual cohort, and others who continued to isolate them. And there was also the issue about when we allowed patients to return to dialysis from those who had tested positive, whether they returned after 1 week or 2 weeks, or whether they required a negative nasopharyngeal swab. So there were the different policies that we seem to be conducted, being used across London, and we thought we ought to try and compare what happened in centres that use different policies like this. Can I have my next slide, please? So what did we do? We got buy-in from all 7 units. It was great to work with colleagues from across centres, both medical staff and nursing staff from across the 7 London renal centres, and we collected data on all the patients who were on in-centre haemodialysis on the 1st of March of 2020. We excluded people who were on peritoneal dialysis and home haemodialysis because we were particularly interested in the in-centre issues. We collected data on attributes of the dialysis units, so how big they were, how many patients they had in them, and some physical things about what the space was in the dialysis unit and the waiting room, how many side rooms they had. We also collected data on the infection control policies that I've already illustrated. And because we had patients the first part of patients postcode, we could also try and assess the contribution of local disease burden on the disease in the particular dialysis unit, to try and untangle how much of this was happening within dialysis units and how much of this was just a reflection of what was going on in patients' own community. So we ended up with all data from all 7 London renal units, and we had about 5,700 patients, which we analysed from 51 different dialysis units across those 7 centres. So can I have the next slide, please? This is just to show you the first wave, the infections in the first wave. The bar chart represents the infections, swab positivity in the units, and the dashed line represents the community prevalence from ONS data. Sorry, not from ONS data, from Public Health England data across that first wave as well. And you can see that they follow each other reasonably similarly, although perhaps the dialysis units were affected before the rest of the population. We use a couple of different outcome variables, both swab positivity based on PCR, but also admission with suspected COVID-19. And because it actually turned out there was quite variable access to swabbing during the first wave, we also just used an outcome of admission with respect to COVID-19, whether you had a swab or not, because I know that certainly some centres struggled with PCR testing, particularly those who weren't admitted. So try and make the centres comparable, we also used an admission outcome. Next slide, please. So I'm going to show you a number of outcome slides with the associations with either a positive test or admission, or just admission, so to exclude the problem with access to testing. And we looked at individual factors, although these have been reported previously. Age, unsurprisingly, was important, as was diabetes. Interestingly, we didn't see the associations with ethnicity and deprivation that other studies have reported on. And perhaps that's related to the fact that these patients are in dialysis units, and maybe that's a bigger risk than some perhaps the population you come from. But yeah, so we saw associations with age and diabetes, but not ethnicity or deprivation. I'm going to focus on the unit stuff and the policies in a second. So if we could just move on to the next couple of slides. So community. So these data, we then looked at the effect of the local community COVID-19 incidents. So we took data from the COVID dashboard from PHE, and we mapped patients' home postcodes and the number of COVID-19 cases in those postcodes with each week. And you can see here the first week here, 2nd of March, and going through the kind of the yellowy brown colour you can see kind of merging out in the background is the number of incident cases in London by postcode. And you can see it's kind of like an upside down Mercedes sign, actually. Northwest, northeast, and central south seem to be the most affected areas in London. And you can see then all the dialysis units marked on that, and the depth of the redness of the dialysis units reflects the cumulative infection rates and swab positivity in this case in each of those units. And you can see that actually that the same community areas that are affected, the dialysis units in those community areas are the same units that are badly affected. That is northeast, northwest, and perhaps a little bit in the south. You might notice one other thing here, which is the size of the circle represents the size of the unit. And you can see here again that bigger units get darker quicker and stay darker, and that also reflects the association with size of the unit I'll talk about in a minute. But clearly, the number of infections that were going on in the local community affected the risk of infection within any dialysis unit, suggesting that transmission within local communities for patients was an important contributor to their risk of COVID-19. Can we go on to the next slide, please? So looking at unit attributes, so we've found a number of associations with things about a particular dialysis unit. The number of patients and the number of stations, which of course are highly correlated, are strongly associated with outcomes. So the bigger units with more patients in had more risks of both testing positive and admission. The size of the dialysis area, although again, this is related to the number of patients. I mean, even if you correct for the number of patients, there are some very big units with very small amounts of area, as well as some very small units with not very much area. So these are all correlated, but it's difficult to say if these are independent, but certainly the bigger dialysis areas seem to have, those with more space in the dialysis area seem to have less risk. And that's also reflected in the distance between the stations, which is another way of measuring the same thing, as well as the number of side rooms. So the more side rooms you had, again, the less risk, certainly for test positivity that you would see. We looked at the policies and the policies of whether you moved dialyzed patients off-site once you knew they were positive, whether you isolated symptomatic arrivals off-site, whether you return test negative patients to usual dialysis, whether you return test positive patients after 2 weeks versus 1, or indeed whether you return test positive patients only after they've had a negative test, actually didn't seem to influence the risk of disease or admission in the dialysis unit. So it looks like there's a number of attributes about the dialysis unit, physical attributes about the dialysis unit itself that affect risk, but not so much what we did with patients who at least we knew were test positive. And there's one more slide here on our findings. Thank you. One thing we did find an association with was the introduction of masking of asymptomatic patients. Everyone was masking patients who we thought had disease, but when across the centres, masks were introduced for patients who didn't have symptoms at different times. And there's an illustration of that at the bottom here of how we look at that. Because obviously there's a lag between the time that the masking was introduced and the outcomes of being admitted to hospital, and here or testing positive. And here you can see it takes about 2 weeks after the introduction of masking for patients who don't have symptoms.
My Uber's 5 minutes late.
Sorry, I'm about to finish. Maybe that's not someone talking to me. And after about 2 weeks, we see a protective effect of introducing masks for patients who are not symptomatic. Okay. Okay. Someone said something about hospital transport, which unfortunately we didn't have a chance to look at in much detail. Last slide, please. So summary, limitations, and conclusions. We saw a number of patient level factors that are associated with the risk, which are unsurprising because they've been reported previously. We found that community disease burden, so the number of cases that were going on in patients' home communities, was certainly affected the number of cases in the dialysis unit locally. Some physical attributes about the size of the unit seem to affect the risk of developing disease, as well as the introduction of masks for patients who didn't have symptoms. So I think these findings suggest that both introduction to the unit from outside, from the community, and transmission from within the unit, and particularly from those who don't currently have symptoms, were important factors. And I think it's interesting that the policies that were surrounding when patients already had symptoms, we couldn't find associations with, whereas the policies aimed at those who didn't have symptoms, like masking, we did find associations with. I guess there are lots of limitations. I haven't got time to talk about through. We did have limited power to detect smaller effects, but yes, I think looking at those who had asymptomatic infection may be key to preventing further outbreaks in dialysis units. And I think that's all I've got to say, except if you put my last slide, there's lots of thank yous across both the group, both medical and nursing staff who helped collect the data, and thank you also to working across London in such a collaborative way, which has been great and a really brilliant experience for me and I think the rest of the team. Thanks.
Thank you very much, Ben. I think that's been very useful and powerful data, and it's really good to look back on it and see that we can pick up some associations. And the masking is interesting, isn't it, with the new data coming out from the Cambridge Union about FFP3 masks being much more effective than simple surgical masks. So there's probably more work to be done in that area.